PSA value over time, and it goes up slowly, and then suddenly changes direction, goes up fast. Is that a strong, medium, weak indicator of?
It can be.
Good.
So, you know, again, everything is gray. And that's one thing I did.
Meteorologist.
Yeah, right, exactly. We're a politician. The one thing I didn't mention was rate of change of PSA. That's another big indicator I didn't say. One of the most important factors isn't just the threshold, but following it over time. So looking at PSA over time, and if there is a change, we don't rush it to the operating room, but we repeat it and make sure it's real. And get repeated values to make sure it's a real value. And if you do see a spike, that's a red flag. But you got to make sure it's a real spike. There can be lab errors. There are other reasons, and we'll go into this, other reasons PSA can be elevated, not just due to cancer. So you have to make sure.
On that scale, you have that relative risk by age. Let's say 70 to 79, you got a scale of 8. Is that the percent? That 8% of people who are that age are likely to have acute urinary retention?
So the risk that you would risk over sort of the other groups. So kind of the 8 times the risk, relative risk of compared to the other groups. 8 times the risk, if you think of it that way. So, similar to kind of what you were talking about, how can we determine who's at risk of developing worse disease? All you guys are in here and I say, okay, who's going to develop worse disease as you get older? There have been a lot of studies, and the higher the prostate volumes, and the patients that have higher PSAs are more at risk of developing problems in the future. That's worsening symptoms, worsening flow rates, higher rate of the retention, and higher rate of needing prostate surgery in the future. So to summarize again, the doom and gloom of this is that BPH is progressive. Prostate size increases with age. Symptoms worsen with age. Flow rate, voided volumes decrease with age. And retention and need for surgery increase with age, along with the volume in the PSA. Now, that's as a whole. That doesn't mean you as a patient, this will happen to you. There are some patients that your prostate may be the same size and it doesn't grow, but as a whole, as this entire group, that's the trend.
Don't get old.
Don't get old. Or if you do, have a urologist as your friend.
That protein antigen, is there any other part of the body that could produce the same thing in your bloodstream?
There are other reasons. The PSA is produced solely by the prostate, but it's not produced solely by prostate cancer cells. And we'll go into that. But it's specific for the prostate.
What's the difference between hyperplasia and hypertrophy?
Hypertrophy, they're for the most part one and the same. They're interchangeable. I may have interchanged them. They're sort of pathologically, if you look at it under slide, they're hypertrophy, hyperplasia, for the most part interchangeable. So treatment, we've determined you have BPH, we've determined you have symptoms. You should really only treat patients that have symptoms. We sort of talked about the progression. Okay, we know that patients with elevated volume and PSAs are more likely to do worse. So does that mean if you come into my office and you have an elevated PSA or a large prostate, should I treat you? No, you really shouldn't, as long as you're not having symptoms and not having problems. You really should only treat the patients that are having problems and having symptoms. Some patients have very large prostates, but the way it grows outward and doesn't affect the urethra, so you're fine. The bladder's emptying well, you have good flow, you have no problems. Conversely, there are some patients with very small prostates that just the way it grows inward, therefore it blocks the outflow of urine. So it doesn't always match. You still have to treat the patient. Okay. So what do we have for you if we do need to treat you? We can wait. Things may not get worse, although again, as a whole, things do. We have lifestyle modifications. Those are actually pretty effective. Medications, which we touched on and we'll talk a little bit more about. Herbal supplements, which is a hugely popular thing and very controversial. We could talk 2 hours just on that. We have prostatic stents, which are little devices that go within the prostate and allow the prostate to stay open. And then we have minimally invasive treatments and some more less minimally invasive treatments down below. So lifestyle modifications, things that you can do to sort of help yourself at home. limit your evening fluids. If you go to bed at 10, stop drinking fluids around 7. If you drink a whole gallon of water at 9, 10 minutes before you go to bed, you're going to have to pee in a couple hours. That's just sort of common sense. But sometimes it's not common sense, and until someone sort of points that out to you, say, oh yeah, that sort of does make sense. Alcohol is a diuretic. It will make you pee more. It will make your kidneys produce more urine. So if you're drinking a couple glasses of wine at night, that may be a reason. Cut that back to maybe 1 or none. Caffeine and sodas do the same thing. Tea as well. If you take diuretic medications, the point of the diuretic medication is to get urine out of your body. If you take it at 7 p.m., you will have to urinate in the evening. So take those in the mornings. Now, if your cardiologist instructs you in a certain way, then that may be more important. But that's something you can do. Another common sense: avoid going to bed. Sometimes it's not as common sense as you think, and you'd be shocked that some people say, "Oh, that's a good idea." Double voiding is another thing that can help. Urinate, wash your hands, wait 2 minutes, go urinate again, whether you need to or not, whether you feel like you have to or not. You may be surprised at how much comes out, because you may not be emptying completely the first time. So if you empty the tank completely before you go to bed, that may save you another couple, hour or two of sleeping. All right, so the medical treatment, again, we touched on these: the alpha blockers, the 5-alpha reductase inhibitors, and the anticholinergics. So we'll kind of quickly go through these again. The alpha blockers, what they do, they prevent symptoms. Okay, some of the ones we are familiar with: Flomax, Uroxetrol, Rapaflo. You see those on all our golf channels and golfing commercials. Again, what they do, they block these receptors and relax the prostate and relax the bladder neck. So you go from this to this, and you can see how the channel really opens up. Okay? It dilates the urethra. The advantage of these medications is they act very quickly, very quick onset of action, days to a week at the most, and you will notice some difference. If it's going to work, you'll notice it. They do have side effects like every medication. You can have some dizziness, some lightheadedness. It can drop your blood pressure a little bit, especially if you're on a lot of blood pressure meds already. You can get what's called retrograde ejaculation, and if you think about it, it's actually a good thing because it means the medication's working. Ordinarily, the ejaculate, the semen come in about right here in the prostate, and then your bladder neck tightens up and the ejaculate goes outward. Well, if this gets relaxed and these things open up, some of the ejaculate may actually go backwards into your bladder. So it actually means that the medication's working, so you may not notice as much or even any ejaculate come out when you ejaculate. It's not harmful, it doesn't cause any problems unless you're trying to have a pregnancy, but you just urinate it out afterwards. It's reversible, so it stops when you stop the meds. But I always warn guys ahead of time, because initially when I didn't, I had several panicking phone calls a few days later. So I always warn guys ahead of time.
Are you able to take those medications indefinitely?
Are you able to? You would need to. If you stop taking it, the symptoms would just return.
What is the drawback, like when you go to donate blood? The Flomax is one of them that's up there. They will not let you donate blood.
Probably because of the hypotension factor, I would guess. I don't know for certain, but I would imagine. If it has the potential to drop your blood pressure, then if you're getting a pint of blood out of your system, that's going to drop your pressure too. So
I think it's added, but it's not recommended.
Is that what it is? I don't know. I would imagine, I don't know why that would be.
Yeah, I mean, when you donate, they have a list, and they say if you're taking these medications,
then you can't.
The first one is Flomax.
Really, Avodart as well. I'm not aware of that.
Not good for pregnant women.
That I can imagine, yeah. Because again, it blocks the conversion of testosterone to dihydrotestosterone. Therefore, you get more testosterone. Pregnant women, you don't want a whole lot of testosterone on board because it can create lots of problems with